I'd like to talk with you today about prescription drug costs, which are understandably a very complex and difficult topic. But what is not complex or difficult is the fact that in the United States, we overspend on healthcare compared to any other country in the world. And we're not getting the value for that. It turns out this overspending is no accident, but it is avoidable. And today what I'd like to talk with you about is share with you some of the research and some of the tools that have been developed by the scientific community to address what's fundamentally a question of value in healthcare and propose a solution. I want to talk to you about comparative effectiveness research. This may sound like a really big term, but what this body of literature does is performed all over the world at universities and nonprofits, is it asks the question of our healthcare services, what's the best value? And what they do is they take a condition, for example, a health condition, they look at all the treatments that are available for it, let's focus just on drugs today, and they ask the question, of these possible drugs, which one works best for this health condition and this patient population? In fact, this data is so powerful and it's so informative that many of these countries listed here, as well as many others around the world, use this information to create lists of drugs that are utilized and also paid for within their countries. But this is not how we do it in the United States. And it gets worse because we think that the FDA does this for us. A Brigham and Women's study asked physicians what they believe the FDA does, and 73% responded that they believe that FDA approves new drugs if they're better than old drugs. That means physicians, 73% of physicians believe that the FDA uses comparative effectiveness research in making decisions about which drugs to approve. Unfortunately, this is not the case. The FDA, as our drug regulator, does a lot of good things for us, and they do use a lot of scientific information. But they do not require drug manufacturers to prove that their drugs are better than existing medications in order to get approved and get on the market. Their stance is that's somebody else's job. Somebody else needs to come and figure out which drugs are going to get used and which drugs are going to get paid for. So in the United States, what we have are two large payers, so to speak, if you want to think about who pays for drugs. Government is one large payer, as well as employers. And what these organizations do is they hire somebody, a middleman, to go look at all of those possible drugs approved by the FDA, allowed to be purchased in the United States, and they come up with something like this. And you've probably seen some version of this in your health plan, right? All you know about prescription drugs is here are the drugs that are covered. Here are the drugs that your company, your insurance provider will pay for. And you don't really get much more detail beyond whether they're a brand or a generic, which just tells you a little bit about what you're going to pay in copays. The question we want to ask, though, is comparative effectiveness research being used to create these lists of covered drugs? Because we know it's not living at the FDA, we know they're not doing it, and we know every other country in the world uses this data to figure out what's best. Let me show you a tool developed by this research community to help us visualize how valuable this approach can be. This is just a simple plot, but what we can do with this research is we can look at measures of effectiveness. So for example, how well the drug works can go here on the horizontal axis. So right, good, left, bad. We can also look at side effects. So more side effects up, bad, fewer side effects down, good. And now you can see, again, compared to what? We always need to ask that question in healthcare. It could be compared to nothing. It could be compared to another drug. But compared to something, drugs that are more effective and have fewer side effects, no-brainer. Those are really good drugs and really high value. Conversely, drugs that are less effective and have more side effects, another no-brainer. Those are not very good. And look, we've got two options that are significantly better. And understandably, there's another category where you have drugs that are more effective but also have more side effects. So there, what we need is more information. Now is when we can start to look at cost. So let's go back to that list of covered medications that I showed you. Now that list is an actual real list from an insurance plan. So I decoded all of the names, but this is true. And what I'm showing you here is actual comparative effectiveness research for these medications. And what they do is they treat blood clots in the legs and the lungs. which you may need after surgery, for example. The first thing to note is that there are more medications than are covered. The second thing you may want to point out, is that look at how these spread out across the chart. Some are good, some fall into, we've got 2 drugs that fall into that good category. We've got quite a few up there that have more effectiveness but also more side effects. So if we look at the medications that our hypothetical drug plan but real drug plan actually covers, what we see is kind of interesting. So they cover the standard of care, drug G there in the middle. They also cover the best drug, drug A. That's great news. But what about drug B? It's got more effectiveness, but it also has more side effects. So now let's look at cost. I'm finally coming to the topic I promised you I'd want to talk about, but I want to talk to you about cost through this lens. If you're confused, so am I, and so were we when we looked at this data. But what you're seeing is true. Drug B on the market is $95. It's 9 times more expensive, and yet it's less effective and has more side effects than drug A. What should be also startling is that drug G there in the middle, less effective, more side effects, why is it the same cost as a drug that's actually better for you? What's clear when we look at prescription drug costs through the lens of comparative effectiveness research is that this research is not influencing decisions in the United States that in turn influence you and decide which medications you will have access to through these lists of covered medications. So, someone, somewhere in our pharmacy system is misincentivized. And this is another difficult subject. How do we figure out who's misincentivized? Well, one way we can do that, admittedly it's complex, but one way we could do that is we can look to see who do pharmaceutical manufacturers incentivize? They're the ones that are trying to sell their medications and get them on the market. Maybe if we look at where they devote their dollars, we can start to figure out who might have a misincentive. Well, if you were to ask around, and maybe some of you are thinking of it, it's got to be all those ads we see on TV, right? Bombarded with them. Here's the data. Pharmaceutical companies spent $6 billion on those ads you see on TV, but what they spent in rebates and discounts to get their drugs listed on those covered medications lists and to get them sold was $150 billion. So if you thought it was ads, this influencer is 25 times more influential, even if you don't know who they are. So it's unclear exactly where that $150 million goes, but we spend about $450 billion on drugs, so that means that 1/3 of what we spent went to whoever these companies are. And industry experts expect that that is largely middlemen. These are the same middlemen that create those covered medication, those lists of covered medications. But who are they? Why are they so influential? It turns out these middlemen are not really middlemen. They also own most of the pharmacies in the United States. That's why they're so influential, because they not only get to control which drugs are covered and which drugs you end up using, but then they also get to turn around and sell you those medications. And this is pretty simple. If you're a pharmacy, do you want to sell an $11 medication or a $95 medication? Comparative effectiveness research is an incredibly powerful tool, and it's everywhere, and we can use it to harness and get more value out of our healthcare. Who can help us do that? Is it pharma? Well, we want them to do more of these studies, but at the end of the day, if their drug is worse than their competitors, they still want to sell it. So we don't want them owning this conversation. What about middlemen? They're supposed to be doing this for us, but if you rewind 20 seconds, you'll see why actually, at least in their current incarnation, they're not the greatest people to bring this forward. Government is a solution for some countries. It may or may not be a solution in the United States. What about employers? Employers are best positioned to harness the value of comparative effectiveness research. And it's because most employers don't actually buy insurance. they actually become insurance companies. And that means that they're the ones actually cutting the check for the total cost of prescription drugs on your behalf. What that means is that they now have control. And in fact, many employers independently, as well as part of large consortiums, are starting to say, hey, we have ceded far too much control to middlemen, and we're not getting the return on having given that control. So they're taking it back, and they're using evidence-based tools, such as comparative effectiveness research, to build you better health plans. Now, what about you? Here's some more data. You, unfortunately, only pay for about 18% of drug costs. It turns out government is about 42% and employers about 40%. So it's tempting to look at this data and think, you can't really do anything about it. But wait, it's your tax dollars that fund Medicaid and Medicare. And it's actually your lost wages, because employers have to pay so much for benefits, they can't give you more salary increases. So you're actually subsidizing all of this prescription drug costs, maybe not directly. But you are the most important influencer in this decision. And the most important thing that you can do is educate yourself. Comparative effectiveness research is publicly available, published by nonprofits and universities. It's out there. Become aware of it and learn about this tool. And then go ask questions. If you're in a self-funded company, ask your HR department, hey, how did you build our health plan? If you get your benefits from Medicaid or Medicare, talk to your congressperson and ask them the same question. Our pharmacy system is not an organic system. We developed it as people. So at the end of the day, we as people are the ones who need to fix it. Thank you.